Hello and welcome to Chapter 9. This chapter is going to be focused on the musculoskeletal system and the disorders that are associated with it. Here's our review on our bones. Just note that there are so many types of bones in our body. We have long bones, short bones, flat bones, irregular bones. All of these bones, of course, help support the body structure. But it's important to note that even at the cellular level, you do have different types of bone cells to be aware of. You have osteoblasts, which help to produce bone, and then osteoclasts with a C that help to break down bones. And also, when we refer to mature bone cells, we call those osteocytes. Also, note that we do have different types of bone tissue. Although this is not the purpose of our pathophysiology course, I do want you to be aware of the different tissues. You do have spongy tissues, you have periosteum, which is a type of connective tissue, and then you have the endosteum, which is full of osteoblasts, which help to produce bone. So again, this is just a simple A&P review about bones, and just know that there are various types, shapes, and they all serve different purposes to help with structure and function in the body. So we just talked a lot about bones, and the next thing I'll be talking about is skeletal muscle. When we talk about skeletal muscle, these are muscles that are directly located on the skeletal bones. They help us with a variety of options. They are a voluntary control system, so we can move them on command under most conditions. But ultimately, they do help with body movement. They help us to maintain our positions with our body. They also help to stabilize joints and to produce heat. Our muscles also, and particularly our skeletal muscles, they store oxygen in the form of myoglobin, which is a muscle type of oxygen store cell. They also help us store glycogen, which would eventually be broken down for energy. You can note that there are lots of connective tissue in these areas, and reasonably so, because that's what helps us maintain that body position. And again, you do have this well thought out system with your body. So one can imagine if any of these areas are malfunctioned, or if you don't have a lot of oxygen in your muscles, or if you don't, if you damage the muscle overall due to a trauma, one can see how all of these areas producing heat, stabilizing joints, body movement, and body position can be affected. You have different types of connective tissue in your skeletal muscles. You have the epimysium, perimysium, and endomysium. When we talk about the epimysium, this one is connective tissue that surrounds the entire muscle, whereas the perimysium, they're small bundles of muscle fibers, and they surround the fascicles within the muscle. And then you have the endomysium, which surrounds the individual muscle fibers. So that's a little bit different from the epimysium, which covers the whole muscle. These actually cover the individual fibers that make up the muscle. Another area that we need to review is neuromuscular transmission. So it's not enough just to have the muscle and the skeletal bone. You also have to have something that helps communicate information from your brain to the muscles to help them move. This is what also helps with that voluntary control. So we do have nerve endings that innervate our muscles. And this is what helps to transmit impulses that ultimately create a contraction in your muscle fibers. And as we remember, contractions is what helps us move our muscle. So you have the different steps here. You have the arrival of action potential, and then you have the depolarization of the presynaptic terminal. And in order for that to happen very well, you have to have a calcium influx. And so we think of our bones and we think about calcium. This is where calcium comes into play when it comes to communication. So you do have to have calcium not only for the bones that you have here, but they also help with muscle contraction. And also, if you remember in your electrolyte imbalances, hypocalcemia versus hypercalcemia, you do see some musculature effects, and this is why, because of the innervation of the muscle. So you have exocytosis of acetylcholine, and then you have the diffusion of acetylcholine to the postsynaptic receptor. After that, you have the generation of the muscle action potential, and that release of calcium helps with that. And ultimately, you have the power stroke, which helps you have that contraction. So, again, the biggest issue with this neuromuscular transmission is in absence of calcium or in excess of calcium. Either you're going to have more of a muscle contraction in your muscles, or you're going to have muscle spasms or not as much of a contraction. You may have muscle weakness as a result. So these are our generalized diagnostics. These are different things that help us to look at different disorders. You have bone disorders, muscle disorders, joint disorders. So they generally all follow the same suit with the few minor exceptions. So let's talk about bone disorders. In order for us to look at the bone level, you'll have to do something called a bone scan. And this is where you have radioactive material that we inject into a vein. Normally it's injected into an IV, of course, and what happens is that imaging substance helps us to create an image. That way we can see exactly what's wrong. As you know, there's blood flow through our bones and through various areas of the body, so that IV substance would essentially go throughout the whole body, and once they scan that particular area in question, they're able to see if there's any malformalities. Of course, you have x-rays and CTs that you can use here as well. The next one we have is a muscle disorder, and one of the main ones that we use for muscle disorders is called the EMG or electromyography, myo meaning muscle, and you can also biopsy the muscle. As we've discussed in previous lectures, biopsy is for live tissues, so you would be excising live muscle tissue in order to examine it and see if there's anything going on with it. Electromyography is also a little bit of an invasive procedure. It's a small needle, which is considered an electrode, and it's inserted into the muscle in question. That way they can measure the electrical activity going through that area of the body. It also helps us to evaluate their health and see if there's electrical activity making it to their, or if there's hyper-electrical activity. It'll help us evaluate both. The next thing you have is joint disorders. And of course, with your joints, you have your your x-rays, you have your CT scans, you also have your MRI imaging, which are pretty common across the board. But one that's specific to your joint disorders is your arthroscopy. And this is a minimally invasive procedure. All they're doing is kind of looking into the joint and seeing what could potentially be wrong with it. They may also do a synovial fluid examination. Normally in your joints, you have a fluid called synovial fluid that helps with the mobility of that joint. And sometimes the synovial fluid question is what's affecting that joint. So they'll also examine that as well and make sure there's no infectious organism in it. So here we have various types of fractures, and when we talk about a fracture, this is general terms, a break in the integrity of the bone. Of course, these can be caused by stress, these can be caused by cancers or neoplasms, traumas, these can be secondary to other disease processes, and of course, the most obvious one can be a trauma or an accident that causes an injury to that area. You have different types of fractures. I do expect you to know these and expect you to know how they look. As far as a complete fracture, you have a bone broken that creates at least two separate pieces. So you have to have two separate pieces. An incomplete fracture is where you have a partially broken bone. You can have closed fractures where there is either an incomplete or a complete fracture, but the skin is not broken. You don't see anything that has, or any bones that have punctured the skin. In fact, it actually remains intact, but you can clearly see that there's a malformality with that. You can have a simple fracture, which is a single break, and that bone is maintaining its alignment and position, whereas you have comminuted. That one is where you have multiple fractures and multiple bone fragments, so that's a difference there. You can have a variety of complete and incomplete fractures with the comminuted type. You can have a compression fracture where you have a crush injury and it collapsed into very small pieces. You can have an impacted fracture where you have a bone that's supposed to force into an adjacent bone, causing a fracture in that area where they were forced together. And then remember how I said you can have fractures that are secondary to disease processes. Normally, this is called a pathological fracture, and this is resulting from an inflammatory process or an infectious process that causes your bones to be weakened. I do expect you to know all of these types of fractures on this page, and do know that some of these types of fractures can coincide. Again, I said you can have a simple fracture but also be a complete fracture. You can be a closed fracture but also an incomplete fracture. So sometimes these exist in tandem with each other. You have more fractures here to learn. You have the stress fracture, which is the bone has gotten tired and it just breaks. Again, you more so see those from pathological fractures. You can have a depressed fracture where this was specific to your skull and there is bone that is forced into the brain. Again, you see a lot of these with your traumas and motor vehicle accidents. You have a transverse fracture where that fracture is a straight line across. You have your linear fractures. You have oblique fractures. You have spiral fractures. Um, you have all kinds of fractures here, spiral fracture. But again, the ones that have the definition specifically on them, those are the ones that I want you to know. But do know there's a variety of fractures that you can have. So again, this is our first type of disorder, and this one is specific to the bone. You have fractures that can happen for a variety of reasons. As I've mentioned, it could be the result of neoplasms. It could be the result of traumas, motor vehicle accidents. It could be the result of falls. It could be the result of multiple things. Ultimately, that fracture can initiate an inflammatory response, which results in the bone not being intact. You do have bleeding in the area of the fracture, and you may even have soft tissue damage on the skin. Of course, you're going to have edema, you're going to have swelling, and then there is some stretching of the periosteum, and even that soft tissue that can cause pain and tenderness. As I've mentioned, you have incapacitation or loss of function. You can have crepitus, which means that there's a grating, popping. Um, and one thing about a fracture that you should know as a nurse is you never want to move a broken limb to test for crepitus. If you don't actively hear it on your assessment, it's best not to move the extremity because you could cause further damage. You could have a hematoma formation, which is a pocket of blood. Again, we normally refer to this as clots, and they form at the site of fracture. And then you may even see systemic signs and symptoms. And the reason why I mention this is because if you have a patient that comes in with a trauma or a motor vehicle accident, sometimes you see multiple fractures and you want to look out for signs of shock. Most times this would be a circulatory shock or a hypovolemic shock because they have lost blood as well. But you'll see paleness or pallor, diaphoresis, hypotension, tachycardia, nausea, and vomiting. So we talked about fractures, but another thing that I want to mention is the healing of your fractures. And please know that our bodies are very smart, they're very robust, they're very nice. And what happens is that you have this series of things that occur at the site of the fracture. So the first thing you should note is that a hematoma can develop in the area in question, as you notice on the right in the picture that is labeled A. That is a hematoma, and a hematoma is basically a pocket of blood that develops that helps to create a fibrin network. Normally you have phagocytosis that helps to remove cell debris. Normally it removes the necrotic bone or it's either reabsorbed. You do have this fibrin mesh that is starting to be created by fibroblasts. Then you have something called a chondroblast that helps to create cartilage. And then you have the formation of a procallus or something known as a fibrous collar. Then this sets the stage up for our osteoblast, and you guys heard of your osteoblast before. These are your cells that help to generate and create new bone. Once that is occurring, you have procallus that is replaced by bony callus. And then that bony callus helps with that remodeling of the bone. And then once it's healed, you will have use that has returned. But the thing is that you have to remember that are different factors that could help this or harm this process. Some things that would affect bone healing would be the amount and the extent of the damage, and how the ends were broken. Were they broken into little pieces? Because that would be very hard for the bone to heal itself versus a linear fracture or a simple fracture where you just have two parts of the bone that were broken. If there is the presence of foreign material, of course, you would have to be treated with antimicrobial therapy. And then you have to think about the blood supply to the fracture site, because this does not work if you're not able to have blood supply helping you get your fibroblasts and your chondroblasts and your phagocytotic cells to the area in question. You could have other factors such as age, nutrition, and even different comorbidities that can decrease wound healing in general. One of those areas would be diabetes mellitus. Diabetes can definitely affect wound healing because, the way that that disease process works. So those are things to think about when it comes to complications of wound healing, and particularly of fractures. One thing you want to be aware of is the infection and ischemia, of course. You can have muscle spasms, fat emboli, nerve damage. Sometimes you do have failure to heal, or you may even develop a contracture or deformity during healing. And you may even have residual effects such as osteoarthritis due to the extent of the damage. So this is where we're going over those complications and details. Sometimes muscle spasms occur because there's pain and irritation as well as strong muscle contractions at that site. Sometimes these muscle spasms can produce residual effects and lead to delayed or deformity development. Um, Sometimes you get soft tissue damage. Sometimes you get more bleeding and inflammation at that site due to the muscle spasms. So a lot of times you will see a muscle relaxer prescribed for people that have had fractures to help decrease this possibility. The next thing that you have to worry about is infections. So again, you have multiple types of infections, but two of the main ones you can get is a bloodstream infection, of course, or you can get tetanus or osteomyelitis. These are a threat, especially with people that have surgical intervention that's required. You would have to maybe even debride the wound to help the body get rid of those infectious organisms. You have ischemia, which is a complication that develops when you have edema or swelling within the first 48 hours. Again, when we talk about ischemia, you have decreased blood flow to that extremity. And sometimes it is because you have a compression by the cast. So you do have to be beware of that. Some things that you would have to watch out for is a pale or cold or even numb extremity. The peripheral pulses distal to the site of the fracture, you would have to assess if they are decreased or absent. Is because maybe the cast is too tight, and maybe it's not because the cast itself was originally tight. Maybe it's because there's some swelling and edema going on in that cast that is compromising the circulation. Either way, you want it to not be too loose either, because as the edema decreases, your muscle is going to decrease due to lack of use. When we talk about atrophy or decreased muscle mass, it's normally secondary to the area not being able to be used as well. Again, something that we look at as a result of casting is compartment syndrome. And it can occur shortly after a fracture and after we have casted it and made sure it was stable. Again, this can start pain, it can start ischemia, and if it's not assessed appropriately, you can get necrosis of the muscle. Another one to look out for is called fat emboli, and this is where you have fatty marrow that escapes from the bone. Again, you do have marrow that is inside the bone, and if it escapes into a vein, you can get issues that travel to the lungs, such as a fat emboli. They can cause respiratory distress syndrome. Sometimes they can disseminate into the circulation system and cause other issues, but most severely it would be respiratory distress and severe hypoxia. Of course, we talked about nerve damage because of the areas of tear. And again, those long-term effects can be osteoarthritis or even stunted growth, depending on how bad the damage was. Okay, so speaking of compartment syndrome, this is something I'm definitely going to ask about simply because it's so important and it's very, very easy to miss if you're not paying attention. So when we talk about compartment syndrome, this is normally when we have a limb or extremity that has been casted and you have edema that develops within one area or one compartment of the limb that has been casted. If you have the significant edema in this area, it will result in ischemia and infarction due to the compression of arterial blood supply. When we think arterial, this is the systemic blood flow that has oxygenation in it. So ischemia would happen first. You'll see deprivation of oxygen, and then eventually it can turn into necrosis or an infarction if it's not treated aggressively. So etiology, it can be tight casts with broken bones, intense exercises, surgeries, blood clots. You can get this from steroids as a side effect, car crash injuries, and trauma. Normally, again, you do see this increased pressure of fluid within the fascia, which compresses the nerves, blood vessels, which causes that pain and ischemia, and eventually necrosis of the muscle. Again, that's very important. Necrosis of the muscle is a very bad thing. Signs and symptoms include pain, swelling, numbness, weakness, pallor, tightness, agitation, anxiety, decreased pulses or absent pulses at the peripheral distal to the injury. And again, you may even see some color change. Like I said, you can be pale or it can be red. It just kind of depends. As far as the treatment, you will get the casted either removed, or we may have to treat the actual extremity itself with the fasciotomy. And this is where you cut the skin into the fascia of the muscle to help relieve the pressure in the area that is affected. Again, this is a condition of swelling. So by creating a cut, you then release the pressure of that swelling in hopes of being able to release that pressure. You would have to have analgesia or pain control for this because that's a very significant and a very deep cut. I actually had a patient that had compartment syndrome, and I'll never forget it because this patient, his leg was he was crushed in a tree, and basically they casted him, but eventually that cast got too tight for him due to the progression of that injury. And so they had to take the cast off, and they ended up having to split his muscle down in his thigh all the way down to his shin to help relieve the swelling. He required lots of pain control, but also we had to be sterile in that area because that was open muscle. He could have easily went septic. We had very frequent wound changes. We did try to keep it covered in some areas because of how extensive it was. But again, this is a very real thing, and you could experience it during your practice. So I want you to be aware that you should assess, and it is an emergency. If you don't intervene, you could run the risk of having a patient getting an amputation. As far as the treatment of fractures, we have 4 or 5 generalized things that we would do. The first thing is that you want the immediate splinting and immobilization. That's a very important part because as long as that extremity is able to freely move, it runs the risk of increasing the amount of damage. So we may immobilize or splint with a cast. You may even use a traction device. Either way, these are areas that we would need to assess first and do first because, again, with more movement within those extremities would cause more damage, so we don't want to do that. The next thing that you want to consider is the reduction of a fracture. And when we talk about reduction, this is how we keep it stable. So what happens is that you have two different types of reductions. You can have a closed reduction where the physician, and again, a physician has to do this, they would exert pressure and then move the extremity back into place, and then they would put a traction device to help keep it there. Or they may even do an open reduction where this is an invasive surgical intervention, and this is where you hear people getting plates and rods and screws in the bone, pins. This is where they would do that. So closed reductions, they don't put pins, screws, and needles in, whereas with the open reduction, this is an invasive surgical procedure, and they will insert devices to help stabilize that bone. And then they also help with debridement or wound debridement. So they will remove any necrotic tissue or tissue that's not viable anymore. They'll get it out with the open reduction. When we talk about traction, this is where we have a weight, normally a heavy weight, that is put on a device that helps pull that limb as opposed to the patient's body weight. What this force does is that it helps to maintain the alignment of your bone, it helps prevent muscle spasm, and hopefully it will help make the patient more comfortable. Normally when we're doing traction, it's to help fix all of these things and help the patient become more aligned so there's not as much pain as well. But traction also helps with immobilization. One thing about traction is that we don't move the weight and we don't transport with the weight. You would have to get the surgeon to do any changes with the weight, and they have to put in their orders for that, because with differences in the weight, you could be pulling on that fracture more than what they intended, and it can cause more injury. So these have to be things with orders, and normally the surgeon that's responsible comes in and does changes with that. Other thing that we can do to treat your fractures is to exercise. Your muscles can atrophy or they will decrease in size without use. So exercises help increase the use of that muscle. It also helps to increase circulation, which is good for wound healing, and it also helps to minimize the possibility of developing a contracture or joint stiffness. So we just talked a lot about bones, so we're switching gears here and we're going to move into joints, and they are very important. They serve as a connection between bones and tendons and ligaments, and they also have little blood supply, which ultimately can make wound healing slow and difficult. So one can imagine having a joint issue can result in delayed wound healing. When we talk about synovial joints, there is a synovial fluid that it surrounds the jointed areas. So you don't have bones that actually touch. They are surrounded by a synovial fluid that helps fill the space between your bone ends. You do have cartilage that covers your bone ends, and then you have your articular capsule, which consists of your membrane or a fibrous capsule. And of course, you have your ligaments that helps to reinforce your bones. They support joints. You have your meniscus that are lateral pads that helps with joint stabilization. And then you have bursae, which are fluid-filled sacs that help add extra cushion. You may see issues in some of these areas with your synovial joints, and we'll talk about some of those issues in later slides. The first issue that we'll talk about is a dislocation, and this is where you have the separation of two bones at a joint, which they lose their articulating surfaces. So this is normally where you see sports injuries occur. Sometimes you have a dislocation due to excessive force in that area. But when we talk about dislocations, you can usually see where that dislocation occurred. Sometimes you can have recurrent dislocations, or you may require surgery for it. The main thing is that you do see the distortion and it does need to be put back in place, but you do run the risk of it reoccurring if it happens one time. We have sprains and strains. A sprain is a tear in a ligament, where a strain is a tear in a tendon. So the way I remember that is strain is with a tendon T, sprain is the other one with the ligament. And then you have avulsions, where you have ligaments or tendons that are completely separated from their bony attachments. It's important to note that you can have muscle tears as well, and these can occur for various reasons: sports injury, trauma, overextension, or overstressing of the muscle. You have repeated injuries that result in fibrous scar tissue, which would normally replace your normal structures. You do have different degrees of muscle tears. The first degree only involves a small percentage of your muscle fibers. Second degree involves much of the muscle, but it's not a complete tear. And then third degree is where you have a complete tear across the muscle. So now we'll move into various bone disorders. The first disorder we'll talk about is osteoporosis, and this is characterized by a loss of bone mass and bone density. You have multiple etiologies such as aging among the older population, particularly in postmenopausal women. You have less osteoblastic activity. Remember, our osteoblasts are the cells that help to create bone, and they help build it up. Again, you have that less effective osteoblastic activity with osteoporosis. Even with having a decreased motility or sedentary lifestyle, you can start seeing the reoccurrence of osteoporosis. You may have hormonal factors such as hyperparathyroidism, which is important to note here. You have something that would cause more calcium influx in the body. Hyperparathyroidism generally increases the amount of calcium in the body. Secondary to that, parathyroid. You have Cushing's syndrome, or you may have continued intake of glucocorticosteroids such as prednisone. Prednisone can cause osteoporosis. Osteoporosis can also be caused by a deficit of calcium, deficit of vitamin D. You can have a decreased protein in the diet, or it could be even secondary to malabsorption disorders. And this is where you ingest enough, but your body is physically not able to absorb the nutrients that it needs. Cigarette smoking will cause osteoporosis. Having light bone structures such as those that are Caucasian or Asian descent, and even having excessive caffeine intake can cause osteoporosis. Pathophysiology, you do have bone resorption that exceeds bone formation. So you have osteoclastic activity that's greater than osteoblastic activity, but eventually you do result with loss of bone. Signs and symptoms are diagnosed with a bone density scan. You may have a lot of compression fractures, especially those in the hip, wrist, and even in the spine or the back. And it can result in kyphosis and scoliosis, which are curvatures in your spine. As far as treatment, you want to increase vitamin D and calcium supplements. You may even want to encourage fluoride supplements. You may have to use a medication called aldrinite, which is fosamax. You have calcitonin. They may have to inject parathyroid hormone to decrease bone resorption. You may have to do exercises such as weightlifting or walking. You don't do high intensity exercises though, because that could break down the bone more. You have a Vista or tamifoxine, which is estrogen receptor modulator drugs. Again, in the case of somebody that has menopause, this would help increase the hormone that is deficit normally, which is estrogen. And then you may even have to have a surgery that helps to reduce kyphosis and realign the vertebral column. Okay, so we have rickets and osteomalacia. So when we talk about rickets, this is the result of a deficit of vitamin D, normally from dietary sources. You don't normally see a malabsorption syndrome with rickets, whereas osteomalacia is a malabsorption issue where you're not able to physically absorb vitamin D or calcium, even though it is present in your body. Sometimes you can have something called renal rickets, which is osteomalacia resulting from severe renal disease. And we'll see this with more so end-stage renal patients, and we would have to replace them because they're not physically able to resorb vitamin D or calcium. As far as the etiology, as I've mentioned, is a deficit of vitamin D and or phosphates. You have people that suffer with seizures that are on long-term phenobarbital, you do see this condition develop as a result of that. And you can even see it due to lack of sun exposure. So as far as how do we deal with it, you do want to try and replace. You want to make sure that you get sun exposure. They may have to either switch the seizure medication from phenobarbital to a different one that does not cause this, such as Keppra. They may have some individuals switch to Depakote. You may have phenytoin. There are other medications that you could switch out for seizures depending on how severe they were. Either way, you do have weak bones that are resulted from this condition, both conditions. You may have deformities, you may have bow legs, and it may even be associated with pain with those weak bones. So again, this is something to look at, and more so with a dietary issue. Okay, so we have Paget's disease. And this disease is characterized by bone destruction. You have the enlargement of your bones, but it also makes them more weak due to the fibrous tissue. As far as a etiology, we don't necessarily know why Paget's disease occurs, so it is idiopathic, but we do know the risk occurs with older age. It is thought to be a genetic disorder, so there are familiar factors that are associated with it, but outside of that, we actually don't know why it would occur. As far as pathophysiology, you have bone resorption that exceeds bone formation, so the result is loss of compact bone, and again, it is replaced by that fibrous tissue, so you will see the enlargement, but those are weak bones because it's not the normal structure of a bone. Signs and symptoms would include pathological fractures. You may have kyphosis, compression fractures. You may have increased intracranial pressure. You may have compression of your cranial nerves, and it also may present as severe pain. As far as the treatment, you want to slow down the process, so we will use bisphosphonates. They actually slow down the activity of your osteoclasts, which are your bone cells that break down the bone, so they stop the activity of osteoclasts and help promote bone formation in that right. So you can have abnormal curvatures of the spine. You have different types. You have lordosis, you have kyphosis, and scoliosis. When we talk about lordosis, that's where you have the curving inward at the lower back, or they also call this a sway back. Kyphosis is also known as a humpback or a hunchback, and you have the abnormally rounded upper back, where scoliosis is where you have like an S or C-shaped curve in your spine. As far as the etiology, when we talk about lordosis, it could be discitis, or you have the slipping forward of your vertebrae, you have obesity, and it can even be genetic. You see the word achondroplasia here, which is a genetic disease, and this is where you have fibroblasts, the growth factor for your fibroblasts that is slowed down, which means that your growth plate and your cartilage will slow down. So that condition in itself is called achondroplasia. You can have kyphosis, and the signs or the etiology would be congenital defects. You may have a spinal tumor or infection. You could have a juvenile version of this called Scheuermann's disease, where you have a hyperkyphosis that involves the disc and the vertebral bodies of the spine, and normally it occurs during growth if we're talking about Scheuermann's disease. You could have poor posture overall, and it could also be caused by spina bifida, which is also a congenital effect. Signs and symptoms would be an obvious abnormal curvature in your spine. As far as treatment, nutritional therapy, there have been thoughts that acupuncture works with this, and as well as chiropractic treatment. Next, we're going into bone tumors. This is probably the only bone tumor we'll talk about due to the time limitations of this class. But I do want to point out that you can have neoplasms in the bone. Signs and symptoms would be bone pain at rest, and you also see a lot of pathological fractures coming from osteosarcomas. The treatment, sometimes you have to excise the tumor or remove the actual tumorous tissue itself. You may have to do surgical amputation, and of course, radiation and chemotherapy are also indicated. You can have something called a chondrosarcoma, which is a sarcoma that arises from cartilage in the cells. And there are different variations of this. You have the child version of this, or adolescence, where that one's called Ewing's sarcoma, and normally that one occurs in the long shaft of the bones. But eventually you do have metastasis from these tumors, and sometimes they have already metastasized at diagnosis. Unfortunately, this does lead to a prognosis that is poor. Sometimes they would discover it soon enough and they would be able to excise it, but you still may see some complications from that. Either way, the pain doesn't develop until late, until there's metastasis, and unfortunately, it may be too late. It is a silent tumor due to the progressive stage until you feel that pain. Again, when you have treatment, surgery is the primary treatment for these sarcomas. Next, we'll talk about disorders of the muscles, tendons, and ligaments. First, we'll talk about muscular dystrophy, and this is a group of autosomal recessive disorders. So you have a gene that creates this defect, and ultimately it does result in the degeneration of skeletal muscle over time. Again, this is a defect. Normally, you do have a deficit of dystrophin, which is a muscle membrane protein, and it ultimately leads to the degeneration and necrosis of your muscle cells. You have skeletal muscle fibers that are replaced by fat and fibrous connective tissue, which would lead to their hypertrophic appearance and makes them look a lot larger than what they normally would be. Eventually, you do have the loss of muscle function. As far as diagnostics, you would have genetic abnormalities. You would have elevated creatine kinase levels. They would have to do a muscle biopsy and be able to determine it. But they can also do blood tests to see what your dystrophin levels are like. And then, of course, they may do electromyography to look at the functionality of your muscles. As far as signs and symptoms, of course, you'll have some motor weakness and regression. You'll have difficulty climbing stairs, waddling gait. You would have to do the Gould maneuver, which would be pushing up to an erect position. You would have reduced tendon reflexes, and when we talk about those tendon reflexes, that's deep tendon reflexes that they're referring to. You'll have vertebral deformities. You may have kyphoscoliosis, which is a combination of kyphosis and scoliosis. You may have contractures. It can progress into life-threatening issues such as respiratory insufficiency. You can get cardiac abnormalities and cardiomyopathy. You can have cognitive delays and infections. As far as treatment, there is no curative treatment available. Normally, treatment is supportive. So if they are having respiratory insufficiency, then you'll see ventilator and tracheostomy support. You may see physical therapy and occupational therapy, helping them to maintain their exercises and maybe even assign supportive appliances to help them maintain their individuality and their independence. But again, there is no curative treatment for muscular dystrophy. This table just shows the different types of muscular dystrophy. You have Duchenne's, and then you have Landowski, you have myotomic, and then you have limb girdle. I'm not necessarily testing you on the different types. I just want you to know more so that they do exist, and this is where you have different ages of onset, different areas where it can progress, and it will show you how rapid versus slow it can progress. This is primary fibromyalgia syndrome, and this is a group of disorders characterized by generalized pain and stiffness. and it can affect the muscles and surrounding tissues. As far as the etiology, we have no idea as to why it occurs. Some people, it can be secondary to disease process, but again, the original thought process is that it is unknown. Pathophysiology is that you don't have any obvious signs of inflammation or degeneration, which makes it hard to diagnose. You have predisposing and or aggravating factors. The onset is higher in women that are ages 20 to 50 years old, and you may have had a history of physical or psychological trauma or even chronic pain. It can present itself as stress, fatigue, and sleep deprivation. Signs and symptoms include generalized aching pain, marked fatigue, sleep disturbances, depression. You may even see irritable bowel syndrome or urinary symptoms due to interstitial cystitis. As far as treatment, stress avoidance and reduction. You want to do regular exercise in the morning, pace activity and rest as needed. You may have to have heating pads or massaging pads that will help reduce the pain. Analgesic drugs, low doses of antidepressants, NSAIDs, and then they may even prescribe pregabalin or Lyrica for fibromyalgia. Next, we have myositis, and this is where we have severe inflammation and damage of the muscles. You have different types: juvenile myositis, you have dermatode myositis, polymyositis, all kinds. But the signs and symptoms will remain the same. You have difficulty climbing stairs or lifting the arms. You feel tired after standing or walking, trouble swallowing or breathing, muscle pain and soreness, and you'll have elevations in your CPK. As far as diagnosis, of course, it'll include the blood test, as I've mentioned before. They would have to do an MRI and a EMG. They'll also need to do muscle biopsies. As far as treatment, because this is an inflammatory issue, prednisone would be appropriate. Azathioprine, which is also known as Imurin, and methotrexate, immunosuppression drugs. Next, we have our joint disorders. Okay, this is osteoarthritis, so don't get this one confused with osteomyelitis. That's a little bit different. Osteoarthritis is where you have a joint disorder, and it is degenerative, and it is characterized by the wear and tear of your joints. You may have narrow joint space due to the decrease in your synovial fluid, or you may even have erosion of cartilage and bone, and it could be the result of increased weight bearing or lifting. Sometimes it does happen secondary to gaining weight. You do have articular cartilage that is damaged. We learned a little bit about that earlier in this lecture. You also have tissue damage causing the degeneration of your cartilage. You do have osteophytes and cartilage that eventually will break off. You do have narrowed joint space as a result of that. And then when that joint space is gone, you do have more inflammation, and it's called secondary inflammation. You do get loss of range of motion. There is pain with weight bearing and use, and you may have bone that's exposed if it's severe enough. You may even get something called osteobites or bone spurs, cysts that develop in these joints as well. As I've mentioned, you have primary osteoarthritis, which is the result of aging, obesity, or weight bearing. Secondary, you have trauma or repetitive use, and it can also be secondary to disease processes. We think that genetics play a role in this, but mostly weight bearing issues. You have signs and symptoms including aching joints and pain. You have limited joint movement. You can't do your normal activities, social activities or recreational activities. Walking is difficult. You may be predisposed to falling. You may have TMJ syndrome, which is temporomandibular joint syndrome, where your chewing or mastication reflex and speaking are difficult. And you may even see bony enlargement in your joints. Osteoarthritis is treated by limiting your stress on your joints. You may have to use adaptive devices such as a walker or a cane. You may have to do pacing activities, or you may have to pace your activities, excuse me, so not doing so much at once. You may have to have inserts in your shoes to help with the pressure, massage therapy, physiotherapy, occupational therapy, glucosamine chondroitin supplements, excuse me, I cannot talk today, You may even have NSAIDs and analgesia. You may have to have an actual joint replacement, especially in the hip or knee. They may do an arthrotomy to help stabilize your joints. And they may have to inject synovial fluid into your joints. So this is where they basically put the same substance. It's a synthetic form, but the same substance inside of the joint to help cushion it so you're not having that abrasiveness on it. Okay, so you have rheumatoid arthritis, and this is an autoimmune disorder that causes chronic systemic inflammatory disease. You have a higher incidence of this in men, but it can affect all age groups. We have no idea as to why it occurs, so it is idiopathic. As far as pathophysiology, you do have synovitis, or you have inflammation in the synovial area. You do get the formation of pannus. This is an important concept for rheumatoid arthritis. You do have that granulation tissue that spreads. You do get the fibrosis, which is the calcification and destruction of your joint space, and then you get ankylosis, where you have joint fixation and eventually deformity if it's left untreated. As far as your signs and symptoms, we have the atrophy or decrease of muscles, you have the shift in your bone alignment, you have contractures, muscle spasms, inflammation in their fingers or wrists, but then it can travel down into other areas. You have red joints that are swollen and inflamed. You are sensitive to touch, painful when things touch you. You have joint stiffness, joint movement is impaired, and then you have even the malocclusion of your teeth, which would develop from TMJ involvement. So what I just talked about were localized effects. You do have systemic effects that can occur, such as fatigue, malaise, anorexia, decreased appetite, low-grade fever. You are resistant with your iron deficiency anemia, so it's unable to be treated. And yes, because of the pain, people can go into a depressive state. As far as treatment, you want to balance rest and moderate activity. You want to have heat and cold applications. You have physical and occupational therapy that can help with movement, NSAIDs and analgesia. You want glucocorticosteroids for inflammation. You want disease-modifying anti-rheumatic drugs such as Gould salts, methotrexate, and hydrochloroquine. You also have biological or biologics such as infliximab, rituximab, and anakinra. So all of these would help with the autoimmune part of this disease process. You do have juvenile rheumatoid arthritis. There are different types. You have type 1, which is also known as Still's disease, where you develop rash, fever, lymphadenopathy, hepatomegaly, joint involvement. Type 2 involves your polyarticular inflammation. Type 3 includes 4 or fewer joints but causes inflammation of your eyes or your iris, ciliary body, and choroid of the eye. Large joints are typically affected in juvenile rheumatoid arthritis. You can have septic arthritis or infectious arthritis, and this is arthritis as the result of an infectious process. So again, I mentioned that this can be secondary to a disease process, so this one is a really good example of that. Usually septic arthritis develops in a single joint. You have bacteria that directly enter the joint by trauma, non-sterile injection, or even through surgery, and it is a secondary infection due to bacteria. You can use antimicrobials over a sustained period, and normally these antimicrobials are administered via IV due to the systemic effects of bacteremia. Next, we have psoriatic arthritis, and this is where you have autoimmune form of arthritis that is accompanied by the skin condition called psoriasis, and we talked a lot about that skin condition last chapter. You do have 5 different types: symmetric versus asymmetric. You have distal interphalangeal dominant spondylitis, and then arthritis mutilans. As far as the etiology, one can say it's because of the psoriasis, but overall it is idiopathic, but it is thought to have some sort of genetic and environmental factors associated with it. But again, we are calling it idiopathic. Signs and symptoms would include swollen tender joints on one or both sides of the body. And again, this is in the presence and accompanying psoriasis. You have swollen fingers and toes, painful muscles and tendons, scaly skin patches that can worsen, flaky scalp, fatigue, nail pitting and separation from the nail bed, eye redness, and then eye pain, also known as uveitis. As far as treatment, you have NSAIDs, you have DMARDs or disease modifying anti-rheumatic drugs, biologics, steroids, immunosuppressants, topical treatments, and light therapy. Next, we have gouty arthritis, and this is the type of arthritis that results from uric acid deposits and crystals in the joint, which ultimately causes inflammation. You have uric acid that accumulates from inadequate renal excretion. Sometimes it could be the result of chemotherapy, metabolic abnormalities, or genetic factors. You have the formation of a tophus, and that's the nodule of urate crystals or uric acid crystals. These tophus can cause local inflammation, and this is where you see the symptoms of gout occur. So you do have swelling, you have pain, you have redness in that area of the joint, and it does require a diagnosis with your synovial fluid as well as blood tests, specifically that uric acid test to see if you have elevated levels. You can get a false negative because you've used NSAIDs before blood samples. So a lot of times they'll ask you not to take NSAIDs. That way they get an accurate result. So as far as treatment of gout, you want to first encourage fluid intake as well as increasing your urine pH, which would help excrete excess uric acid from the body. You may use a medication called Colchicine or colchicine, which is what we use to manage the acute episode, whereas allopurinol is used as a maintenance medication for gout. You will use NSAIDs for pain management, and you overall want to reduce the amount of uric acid from your diet, and of course use the drugs, and they have to be on a consistent basis. But again, once you reduce the inflammation and pain, once you take your NSAIDs, once you take your maintenance medications outside of an acute episode, then normally gouty arthritis can be mitigated. Next, we have ankylosing spondylitis, and this is a progressive inflammatory disorder. It is chronic, and it normally occurs in your sacroiliac joints, intervertebral spaces, as well as your costovertebral joints, and it's common in men, normally ages 20 to 40 years old. We think it's an autoimmune disorder with a genetic etiology, but ultimately it is idiopathic per our perspective. As far as pathophysiology, you have the vertebral joints that become inflamed. You get fibrosis and calcification or fusion of the joints. Inflammation then begins in the lower back. You do get this kyphosis or the hunchback look. And then you have osteoporosis that's also common. One thing to think about is when you have this hunchback, it also does affect the way that your lungs expand because you don't have as much space at this age. It does ultimately reduce your rib movement. So again, this is something that occurs, and it does impact breathing. As far as your signs and symptoms, you'll have morning stiffness, low back pain. The spine does become more rigid, and you may not be able to extend, flex, and rotate the spine as well as you used to. Some individuals have systemic signs such as weight loss, fever, and fatigue. You may get uveitis or specifically iritis, which is inflammation in the eye, and that is a common additional problem. You have other musculoskeletal inflammatory disorders here. First, we have bursitis, and this is where you have the inflammation of the bursae associated with bones, muscles, tendons, ligaments of various joints. Etiology is the repetitive motion on a particular joint. You do see this with people that do repetitive actions in, mechanical work where you're lifting a lot or even turning and doing major turns with a large vehicle. You can see this bursitis develop in the joints of the arms. Diagnosis usually requires physical examination, ultrasound, as well as an MRI. As far as treatment, you do have to have rest and NSAIDs. Next, we have synovitis, and this is where we have inflammation of the synovial membrane, where joint movement is painful and restricted. Diagnosis is the analysis of your synovial fluid for signs of infection. Normally, your signs and symptoms include swollen, red, and warm joint, repetitive motion on a particular joint. As far as treatment, you have NSAIDs, and normally it's because of something else, so you have to treat the underlying cause. Last but not least, we'll talk about tendonitis, and this is where you have irritation or inflammation of the tendon. Sometimes this can be a result of repetitive motion or a trauma. Diagnosis is a physical examination. They will also do some scans on you to see if something is inflamed. Normally, your signs and symptoms are a dull ache and mild swelling. Treatment would be rice, NSAIDs, and physical therapy. Thank you so very much for listening. I know this was a lot in this chapter, so please make sure you listen in and reach out if you have any additional questions. I'll be more than happy to answer them.